Hello, may peace be upon you. It is me, Professor Shukr again. Today I am going to talk about SPICES model. It is a model that explains the educational strategies. A strategy is a plan of action. So what strategies which can be used in a medical education so that the students can learn more? In fact, when I am discussing this, I am explaining what Harden has written in his landmark paper in 1984, Educational Strategies in Curriculum Development, the SPICES model. This is one of the paradigm papers ever printed in medical education. And it has affected medical education so much that everybody uses this model in development of their curriculum. There are many educational strategies. Harden has identified 12 educational strategies. These educational strategies, 12, can be divided into the set of 2, so there would be 6 sets of educational strategies. Each set defines an issue in which these strategies are at the two ends that I am going to explain. But before that, let me tell you the relevance of this and the importance of SPICES model. 6 issues of educational strategies have been identified related to curriculum in a medical school. Each issue of educational strategies is represented as a spectrum or continuum. Because if you take a set of 2 strategies, one on this end, one on this end, then it follows a continuum, and a medical college may decide to develop a strategy in between at any point. Newer schools tend to be more to the left on the continuum, established schools more to the right. If you write the strategies in a row, left side and right side, what Harden in his original paper, as what he has written is newer innovative strategies on the left side of the table and traditional strategies on the right side of the table. Each school decides where it stands on each of the issues. As I was explaining, each issue consists of 2 educational strategies. So each school has to decide what percentage of each of the educational strategies the school wants to use or the medical school has. It can be used in curriculum planning or review. Obviously, if I want to evaluate the program, then it can be used to evaluate and then to upgrade it in its revision using this model. The issues are interrelated and decision about one clearly may affect another. If you see it, these 6 issues, they are not independent. In fact, they are interrelated with each other, because if you change one, it affects the other. Medical schools can decide where they stand on each issue and therefore which particular educational strategy they wish to implement in their school. If you see this table of the SPICES model, on the left side are new innovative strategies. On the left, on the right side are the traditional strategies. In fact, this article was written in 1984, so at that time it was okay to call them new innovative strategies, but they are not that new if you think of. Traditional education strategies are teacher-centered education, information gathering, teaching and learning, discipline or subject-based education, hospital-based, standard program, and apprenticeship-based or opportunistic. In new innovative strategies, it is student-centered, problem-based, integrated, community-based, electives, and systemic. The name SPICES model has derived from each of the words of new innovative strategies. S for student-centered, P problem-based, I integrated, C community-based, E electives, and S systemic. If we want to understand this model, we must understand what are the concepts, what these words means, and what is the concept underlying these 12 strategies. If we talk about student-centered and teacher-centered, in student-centered approach, students take more responsibility for the learning and emphasis is on the students and on what and how they learn. This is opposite to teacher-centered, in which the teacher is the key figure in teaching and learning, and there is an emphasis on formal lectures and laboratory, as many of us has experienced. To take it further, let me explain these two approaches by means of an example. In slide, whatever is written is exactly the words that have Harden. Even these examples are from that article. In student-centered approach, students studying, let us say, physiology, receive a set of learning objectives which outline both the minimum requirements of the course and the areas they can study in depth. Students study the subject individually from the printed material or program tape and slide presentation. Meaning by, students are not given the topic as such. They are told these are the learning outcomes, and from these learning outcomes, student decides what and in what depth he wants to study. In order to support his study, the teachers have developed printed material or program tapes, slide presentations, videos and audios to which the student has access. The students can choose to use the material at the time suitable to them and can take as long or shorter time they wish to study any program. It means the time of the program, the time of the course can vary depending upon what the student capability is and what the student likes. At any stage, they can refer to the standard textbooks or to member of the faculty, and they are learning on their own by making use of the material which has been provided to faculty. But if they have a problem, then they can even refer to the standard textbooks or the faculty is available to them to solve their problems. And students can carry out practical exercises at the time most appropriate to their study of the subject. Now, since students will be studying on their choice, they may be studying some material earlier and some material later. So therefore, once they think they have the knowledge, they can choose which practical they want to practice. They study when they feel they have mastered a phase of course, the faculty arranges for an examination. So you do not have examination like fixed date annual examination or something like that. But the students tell, okay, I know this subject now, can you take my examination? And the faculty then arranges examination. When a teacher-centered approach, at extreme right, the students, taking example of physiology again, student in physiology have 4 lectures and 1 practical class, as commonly occurs in medical education, in medical colleges. To learn, student must attend the lectures. The laboratory work is based on the manual prepared by the faculty. A student is given little opportunity or encouragement to study the subject in depth if he feels like. An examination occurs. An examination If the class failed at the end of the course examination, they have to resit the examination 3 months later or whatever the date is. Feedback on examination result is not provided, nor do they receive help with their study technique. A majority of the college, even now, especially in Asia, they are following teacher-centered approach to think of. But now majority of the medical colleges are practicing both approaches, and in some it may be predominantly teacher-centered, in some student-centered. Why teacher-centered approach is so common is because experience of teachers, they have experienced only teacher-centered approach and may perform better in this situation. Obviously, since they have experienced that approach of teaching, gradually they become expert in that and they think they can teach better and student learns better that way. And similarly, the experience of students before joining medical college, they're exposed to teacher-centered teaching, teacher-centered approach. So therefore they are tuned to that, and to them it becomes difficult to get accustomed to student-centered teaching. Demand on the teachers, since a range of learning experience and resources should be provided to the students, considerable advanced preparation is required by the teachers to meet the demand. So in student-centered approach, in fact, teachers also have to work much more than the teacher-centered approach. Another issue is whether we should have an educational strategy which is problem-based learning or information or knowledge gathering. Let me explain these two terms. In problem-based approach, it is based upon problem solving to develop a usable body of integrated knowledge and problem solving skills. Whereas in information gathering approach or knowledge gathering approach, an emphasis is on formal lecture or laboratory. One must remember, by problem-based approach, what we are referring to is problem-based learning, PBL. Because the purpose of this approach is to use problem-based learning as a vehicle, as a method of teaching to develop a usable body of integrated knowledge. Obviously, to develop problem-solving skills. Carrying it forward, in a problem-based learning approach, students tackle patient problems, health delivery problems, medical science problems, or research problems. So therefore, the trigger point in learning for the student is a problem. They read the problem and decide what they want to learn, how they want to learn, and proceed accordingly. These act as a stimulus for learning in the basic sciences of clinical medicine. The appropriate choice of clinical problem in the early years of the course can encourage the students, when they are studying basic sciences, to integrate the clinical sciences knowledge into them, and they see the relevance of basic sciences much more apparently. Whereas in information gathering and knowledge collection, which is the far right or the right side of the spectrum, the main objective is the acquisition of facts, concepts, and principles. The third issue is whether in a medical college the curriculum should be integrated or discipline based. An integrated approach, the organization of teaching matters to interrelate content of subjects taught in different academic courses or departments across different years. There is a fusion of knowledge of different subjects. There is a discipline based, centers around focus on classical coursework such as anatomy or physiology, with clinical care coming later in program. Just to realize, let us say at the far left corner, an integrated curriculum will be something like that, a fully integrated teaching with no departments or subject-based teaching. Interesting, no department or subject-based teaching. Whereas at the end of the right of the continuum or spectrum and discipline-based, fully subject-based teaching with no integration. The fourth issue is where the teaching should be based. Community-based or hospital-based. This is an educational strategy. In which setting one should teach and students should learn. A community-based approach allows students to receive their training in a community setting that may be a general practical clinic, family home, family planning clinic, or rural hospital, etc. Whereas, as the name tells, in hospital-based approach focuses teaching within the main teaching hospital. There is a difference in the two settings. There is a difference how patients are managed. There is a difference which type of patients go to tertiary care hospital. There is a difference between how a general practitioner deals with the patient or solves the problem of the patient as compared to a consultant in the hospital. Therefore, in community-based approach, during their training in community, students learn about social and economic aspects of illness, health services in a community which may be different, clinical skills obviously are developed, and they also encounter what is the frequency and the type of the medical problem which report in the community, because community that acts as a filter, the community clinics, and a selected patients from them, they come to the hospital. In hospital-based approach, faculty which is hired in the college, it is attached to the medical department in the hospital where they teach. Students spend most of the time listening to lectures, attending tutorials, and attending to admitted patients. They will never see a general practitioner in action in the healthcare, whereas as soon as they graduate, after a house job or internship, they will be general practitioners till they become specialists. Then, what about program? Another issue is, if the educational program should be a standard program, meaning by all students have the same experience, or it could be an elective program in which students have the choice to study what he wants and what depth he wants out of the courses which are offered. Elective approach gives students the opportunity to select subject or project of their own choosing. A standard program does not give students the opportunity to select subject or project of their own choosing. All students pass through a set of prescribed courses with a few of any opportunity to study a subject of their own choosing. And lastly, the sixth issue is systemic and apprenticeship based or opportunistic. In systemic approach, program is designed for all students so that the experience for the training are covered same by all students. Whereas in opportunistic approach, all students do not experience same coverage of content. Now going back to this chart, obviously, ideally speaking, the education strategy which a medical should have are student-centered, problem-based, integrated, community-based, elective, and systemic. But it is difficult to be on the far left corner. Therefore, the medical colleges, they are usually using all the 12 strategies. Since they are using all the 12 strategies, so in any set of 2, It's the percentage of what they are using. For example, if it is student-centered, teacher-centered, a medical college may be using the predominantly student-centered learning and less teacher-centered, so therefore it will be falling somewhere here. But another medical college may be using more teacher-centered, so therefore that college will be falling somewhere here. What about problem-based learning? There are many methods of teaching in a medical college. One of the method is a problem-based learning, an excellent method developed by a headmaster. So therefore, a medical college may not be using any problem-based learning method. Maybe using problem solving or other. So that will tend to fall somewhere here. But if the curriculum has a lot of problem-based learning being used, the curriculum is going to fall here. And so on and so forth. When a curriculum is analyzed, then the SPICES model can be used to place a medical college or university where it is on each of the continuum. And to upgrade and develop, after doing the need assessment, depending upon the resources of the medical college, they may decide, the curriculum development and implementation committee may decide that they have to move towards the left and how much. The question is not this, whether they have to move towards the left or not. Obviously they have to move towards the left, but how much they can move, that depends upon multiple factors. I hope this helps you. Have a good day. See you again.